and welcome to Just Ask, your monthly rendezvous here on the EAO YouTube channel. Now, before we get started, who are you and where are you joining us from today? My name is Hayley Edmonds and I'm delighted to be your host for yet another interactive digital session that connects professionals from all around the world for sessions and discussions on implant dentistry. And when talking about all around the world, today is no exception, as today's guest is joining us from Sao Paulo, Brazil. Welcome, Dr. Gustavo Giordani.
Hello, dear. Good to be here.
Thank you so much.
Actually, I'm super honored to be here and super happy. So thanks for having me here. It's a pleasure.
Thank you so much for joining us today. We can't wait to get our teeth into what is set to be an extremely informative session. And now more about this session. It will be on guided perio-implant surgery. Now, just a little presentation onto your LinkedIn, if you will. Dr. Gustavo Giordani is specialized in maxillofacial and periodontal surgery and implantology. You treat cases interdisciplinary, working with specialists all over the world. You lecture internationally on soft tissues management, periodontology, and implantology in prosthetic treatments. Now, before we get underway, please don't hesitate in asking any questions you may have to Dr. Giordani. Now, this is a fantastic opportunity because it's an interactive session to ask questions at the same time as the discussion. So please don't hesitate. Any question, we'll be happy to answer them. So let's get started. As I said, today we'll be discussing guided perio-implant surgery. So my first question to you is, as a clinician and an experienced surgeon, how does it lighten and facilitate your workload?
Amazing way to start, and actually changed everything to me, Haley. Actually, I started doing surgeries, and I started as a maxillofacial surgeon, and I moved to Belgium to work with my mentor and learn from American Eric Van Doren. And when he started doing guided surgery, I didn't understand why. And I said, okay, he has a lot of experience. Why he's moving to guided surgery? And then when I started to understand how important is the virtual plan, how do you see better when you connect all the files, when you superimpose images, when we put the final design to select like your implant system, your implant design, the prosthetic components, and change and turn this into a guide for the surgery, everything changed for me. So today, in my daily practice, I work with implants and perio surgeries like every single day. And for me to use this kind of technology to amplify the files, amplify the structures, and to see better and to change this to guide system to really achieve that kind of predictability, for me changed everything. Everything that I do in my clinic today, it's like based on guides. I work with a lot of aesthetic rehabilitation with big clinics. So to see the final design, to see the final result, and use this for me to plan and execute in a guide way, for me changed everything. And I feel that I work with more reliability, less problems, less invasive surgeries, more predictability. I think it's cliche, but I think it's a super correct word.
Was it a big step for you, going from freehand and more kind of analog techniques to something more of a digital approach?
Actually, I think it's a mindset. It's not only about like producing guides and doing surgery using guides. It's not about this. It's a really different mindset. You really need to think about that. And as a surgeon, I think all the surgeons has this, okay, I'm good enough to place freehand, so I don't need that. This is just for complex case or for young dentists. And I really understood when I started to learn from Christian Coachman, Eric Van Doren, Florin Kofar, all the digital mentors that I have. And I start to really understand and try to think digitally as a surgeon, for me, that there's disruptive part was, okay, I need to move a little bit from my feelings that I can do, no problem, I have experience, I did a lot, to, okay, let's move with the plan. Let's think in the final rehabilitation, and let's use this in, for me, for my benefits and also for the patient. So I think the key point is when you start to understand the process, how important it is, and why not? That is the question for me. So today I have this kind of a phrase, guided why not? Because today it's so easy to assess. We have more than 30, 40 different softwares to do that. It's not expensive as it was. It's we have like so many good labs and so many good software. So I think now 2023, the question for me now it's why not? The beginning was like, why I'm going to do this? I can do freehand, but now it's why not? I feel more comfortable. I see better. I execute faster. It's better for my patient. It's less invasive. I produce better results for my prosthetic team. So when I look back and I said, okay, I should start it earlier because it's really part of the daily routine.
That's right. As you said yourself, it's a lot more developed now and a lot more accessible as well. We've got some questions coming in already. So Alfonso Gil says, let's get it going. He's getting the party started, if you will. Gustavo, you work with an amazing team. Who decides about the number and position of the implants, you or the prosthodontist?
The treatment plan. Actually, when we get like, let's say, if I'm going to do a simple single implants in aesthetic zone, let's say my patient fractured one central and I have all the references to copy. So I just need to keep everything. Of course, the reference is going to be the position of the existing situation. But when we are thinking about a rehabilitation, aesthetic rehabilitation, who decides the position of the implant is the treatment plan. And of course, is the prosthodontist. I mean, when we are going to move for a final rehabilitation, the position of the implant needs to be related to that. So a very wrong situation is to send the patients with like missing teeth or extraction sites, and the surgeons start to decide placing implant based on just bone. This is pretty wrong, and actually will turn the final aesthetics rehabilitation in a nightmare. So the thing is, first you plan the rehabilitation. You can do it in an analog way. For me, much easier and more precise, do in a digital way. And this rehabilitation, if you're going to change the zenith, if you're going to do ortho, if you're going to prep teeth, change forms, the final position of your implant is going to be related with your final soft tissue and your final rehabilitation. That is the key, for sure.
Okay, just before we go into a bit more detail, and I'm sure you have some cases to illustrate some of your work and processes, I just want to give a heads up to everyone who's joining us today. We have Orlando from who says hello, my friend Guto. Kayla Sebula Nelson from Uganda. We have Rigmore from Stavanger. We have Gilbert from New York. Frederica, who's joining us from Prague. Rida from Tunisia. Maurizio from Porto Alegre, Brazil. Alberto from Spain, Gaston from Cordoba, Argentina. I mean, there are lots more people connected. So firstly, thank you for being present here today and taking part. So let's get this next part started. Do you have maybe any cases to illustrate some of your approaches and techniques that you'll be using?
Sure. And actually, Hayley, if you give me the opportunity, I will have that question to start showing something, okay? Because you just asked me something I think it's very nice to discuss. I just want to show a case really important related to exactly that question, because I think this is super, super important. So do you see my screen now?
We do. Yes, we do.
Perfect. So look at this case. This is a patient that came to me with a completely different situation that we want or she wants. And she said, Gustavo, I want, of course, a better look. And I have like a completely different situation about zeniths. And the tooth that I need to extract is the number 21, which is the number 10 in US. And imagine if I try to place an implant here just related to the situation I have or the bone. I mean, I can make a completely mistake. And of course, I will start planning this case prosthetically, not only thinking about the bone. Okay, so what do we did and how do we use technology like this? So first thing, we talk with the patient. What do you want? Okay, I want an aesthetic full rehabilitation. Okay, so I need to design something. This patient came to us and said, okay, I just want a better look. And I think the reference for us, it's going to be the number 11, which is the number 9 in US. Okay, so the number 11 is my goal, my target, thinking about aesthetics. Of course, we are going to do root coverages and everything. So how do I use technology here? I just scan my patient, okay, full mouth. I ask a tomography, full arch, of course. Then when we start to superimpose everything, then we start to design. And look how nice is the technology. We are just taking our reference from the software. We are using here the 3Shape software. So what we are doing here, we are removing from the tomography the tooth number 11, which is my reference. Then I just turn and have exactly that situation to the number 21, the tooth that I'm going to extract. And after doing this, I'm going to plan the implant. So asking the question, who will take care of the implant position, the final design, the prosthetic design, which is in this case, the natural adjacent tooth. So imagine if I'm going to change like everything, it's going to be like a digital plan, a mock-up that we are going to approve. But in this case, it's going to be our reference. And I did this planning with my partner here in Brazil, Vinicius Machado from Belo Horizonte. And also what I asked Vinicius, and look how nice is technology for us. I asked like a hybrid guide, because I had to remove a lot of soft tissue grafts. And in order to be safe, I just asked Vinicius to map the palatal artery, as we can do with all the arteries. We map that and we just do we open spaces exactly perfectly to remove the graft and be safe to the artery, be safe to the palatal area. So asking the question, who will take care of the implant position, the prosthetic situation, future prosthetic situation? We design everything and then we move to the surgery. Here we are not talking about technology. We are talking about doing in a minimal invasive way. Nothing changing. Technology is helping us to see better, to plan better, and also, why not, execute it in a guide way. You can plan and execute in a free way, but doesn't make it sense to me. I mean, if you can just bring a guide to you to bring exactly the implant, base it on the future restoration, which is something for the surgeon not easy to do sometimes during the surgery. You know, you have like one situation, you need to do the surgery thinking about the future situation. So sometimes you make a mistake, and it's not because you want, but it's difficult to see the future sometimes. And of course, like this, you can achieve. And look what we did here. The design of the adjacent tooth, just we brought to our provisional. And to bring and connect this inside the mouth, you can use like digital trays that we can print. So you put the provisional exactly in the way that we design. And why do we do this? So you don't need to use like a lab at the same time. So you don't need to scan your patient, send to the lab, do everything. And you can do in your clinic, you can do everything before, okay? And you just connect inside the mouth with a perfect design, so you can do all the things you need surgically. Look at the guide. Look at the soft tissue guide, how nice it is. So we plan exactly how much we want to remove from the palate, okay? The length, the thickness, the everything that you need in a very safe way. We removed the guide, the graft, we sutured everything, and we did our aesthetic rehabilitation. But the thing is, and something that I like a lot, everything that is positioned, everything that is designed, everything that is related to something that we can virtual plan and achieve exactly the same or pretty close to the position we planned, I really like to use. I think it's nice because as a clinician, help me, it's less time, you more invasive, and I think it's very nice.
What if you don't have the natural adjacent tooth to serve as a reference there? Would this kind of software use AI and of course algorithms to kind of to predict and to give you two different teeth, for example?
Amazing question, dear. This is something that we are now developing more and more. And now is my Smilecloud, which is a platform that we can talk a little bit. Smilecloud is bringing this kind of artificial intelligence for us, using libraries of natural teeth to bring to you exactly the tooth form that is going to be nice to that soft tissue shape. Yeah. So if you don't have the design, you can use softwares to bring to you the design, thinking about the soft tissue design you have or the future design you want, and you can use those shapes using STL files to bring this to real life printing or milling everything that you want. Like in this case, you see now we had a reference, but just to summarize this case, I'm not going to be like long with this case, but look here how nice it is. Look at the healing. The healing is exactly the same of the design. So as a surgeon, not a prosthodontist, for me to have the perfect design for the healing, for me, it's the best thing. And when we compare what do we have as a planning and what do we see as a result thinking about healing, I think it's really nice. And then we just finish with final veneers, just a few. We did 2 veneers and 1 crown. And just for you guys to see how nice it is and how important it is to first plan the prosthetic part and use technology to that, and then bring that reference to the implant position.
Does this encourage more kind of interdisciplinary interaction, this kind of software?
100%, Hayley. Actually, when we go to interdisciplinary world, when you go to softwares like Smilecloud, and I'm talking a lot about Smilecloud because it's a platform that I use a lot, and it's amazing for communication, to share files, and to bring attention to the team, exactly the final design, exactly the final interdisciplinary workflow based on design. What I learned, Hayley, from Florin Kofar, and it's something that I use a lot in my daily practice, when you first design everything that you want based on what the patient wants and it's what is possible, of course, using digital tools and workflows to design perfectly and bring that design to an interdisciplinary world, it's amazing. Like in this interdisciplinary world, we see like perio guides. I mean, imagine if you are going to do an interdisciplinary treatment, thinking about crown lengthening and veneers and ortho. When you go to these kind of platforms, you design first.
There's we have a slight Gustavo.
Yes.
Are you back with us? Fantastic. Sorry, there was just you froze for a second, but you're back.
Oh, okay, sorry.
Please continue.
And I'm just saying that when you design first, okay, and then you use that design to bring soft tissue guides for crown lengthening based on the design, or if you are going to do ortho and then you are going to move for aesthetic rehabilitation, you can monitor ortho, scanning, and bringing that scan to the final position and monitor the ortho movement with the final design, this is amazing. So the interaction of an interdisciplinary team, okay, using these kind of platforms and the digital tools, for me, I'm going to say, not mandatory, because I don't think it's a rule, but really brings a lot of predictability in this kind of cases. And we usually say, Hayley, that this is we call like a non-reactive dentistry. I mean, you design first, and then you produce all the steps and guides to bring exactly the final design, or really close that final result to the design. When we go to the freehand and analog world, you usually do reacting dentistry. I mean, you develop a design, and then you send to the perio surgeon. He cuts or she cuts, and then base it on experience, and then you react to the healing. And maybe the zenith is not 100%, and then you prep, and then the technician is going to apply the ceramics, base it on the soft tissue design after the surgery. And then when you achieve the result is not really close to what we designed in the beginning. And to avoid that, we really like to go to the digital world.
Nicole Winitsky wants to know, what is your protocol to assure predictable soft tissue outcome? How much does it depend on your experience and skill?
You mean thinking about crown lengthening or like graft surgeries?
What is your protocol to assure predictable soft tissue outcome? How much does it depend on your experience and skill?
Let's say about grafts first, okay?
Okay.
If it's related to graft, I think it's 99% depends of my 99% depends of my experience, because I think on tissue manipulation, thinking about grafts and techniques, I'm not going to put in the digital world account, because of course we can do guides for soft tissue and to be safe, but the tissue manipulation from the surgeon is the most important thing. I mean, how delicate you are, the technique that you apply, the instruments that you are use, how experience you have, like to really bring the result thinking about grafts. I think it's more to the biological concepts and not to the digital world, okay? But when you change to crown lengthen, okay, which is also soft tissue surgeries, then I will put more to the digital world, because when you think about like cutting, okay, like removing tissue as a crown lengthen procedure, you can really use technology softwares to diagnosis, okay, and also to execute in a guide way. I like a lot, was described and invented by also Christian Coachman, the Perio guide. I use it a lot. So I think it's based on skills. Always, everything needs to be based on skills and experience. Okay, this is very important, of course. But when you go for crown lengthen, I think technology helps a lot. Not only for like a natural teeth case to really achieve exactly where you want to cut, okay? But when you go for like rehabilitation cases, when you design something and you want to copy something, to have guides to achieve perfectly the same design in your future rehabilitation, not the actual situation, I think it's pretty important for me. And just to make something important here, I don't think technology makes you better or it's necessary if you don't use, you are out. No, but I think it's really brings a lot of predictability when it's possible to use, you know?
Absolutely, and reassurance as well, and confidence to both for the dentist, but also reassurance for the customer, the client. Orlando wants to know, do you think that navigation CIES gives you the same advantages That's what you've just pretty much said, navigation.
I don't have like a huge experience on navigation. Okay, I saw some friends and some people working with. Do you see me? Hear me?
Yep, I see you.
Yeah. So, but what I see, I think it's very nice. Okay, I'm not against navigation. Actually, I think it's amazing. Maybe is the future. I think it's pretty. I'm not saying new because I know that people is like a lot of people are using like for a long time, but it's not for everybody now. It's, I mean, for Brazil now, it's very expensive, and I think we have like just a few people using. So I think it's the future because it's really dynamic, and I think it's very nice. Okay, but thinking about globally, like to bring predictability like for all the world, I think still using guides it's nice because all the systems are prepared, people are prepared, companies can make it cheap, it's affordable for like a lot of people. So I think navigation is the future, but it's going to be more and more and more and more, but not 100% for now for everybody.
It's currently not a very accessible, hasn't gotten a very accessible standing. So unlike, you know, as you said, with the guides and such like, which are a lot more accessible, and as you say, accessible around the world, for the moment, maybe navigation is something you may see developing a lot more in the future. Arwa wants to know, what type of bone grafting material do you place at the buccal gap of immediate implant?
The bone material that I use for the gap, if I understood?
Bone grafting material.
For?
You place at the buccal gap of immediate implants.
Awesome. I like to use, can I talk about brands here?
You're going to talk about
okay.
Smilecloud.
Yes, I will say because I don't have any financial relation to talk about this. I'm going to
You're
say
not sponsored.
Exactly. I don't have sponsors here, but I like to use Sheno biomaterial. Okay, I like to use BIOS. It's the material that I use for more than 15 years, and for me, it's the best material to do that. Why? Because it's really and fantastically published in the literature, so we know how safe it is. And bringing attention to that topic specifically, which is the gap, what I want in the gap, even if I have like just a gap or a fenestration, or if I lose the buccal bone, I really want something rigid and something that is going to stay in a long term. To support soft tissue. Okay, so when I use this xenograph like BIOS, I know that it's going to stay part of the biomaterial. I know part is going to change by like bone, or part is going to be like soft tissue. I don't care. Actually, I want something that is going to slowly change, and it's going to be very stable in a long term, thinking about like a rigid structure to support the soft tissue. So I like to use biomaterial, and my preference is BIOS.
Thank you for specifying that for Ahwa. I hope that answered your question. So where would you like to move on to now? Where should we kind of navigate with regards to your workflows for guided surgeries for implants in aesthetic crown lengthening?
Yes, I think it's nice because we started talking about this, and I think it's nice to talk a little bit about the technology in this field, because I think crown lengthening, guys, it's a topic that we really do. Like almost every aesthetic rehabilitation is very normal and very common to align soft tissue doing crown lengthening when we are doing aesthetic rehabilitation. So I'm sharing my screen here so you can see. Talking about crown lengthening, guys, I think we have like so many techniques, so many publications, and I just want to summarize a little bit what we did in the past and what we are doing here. So I'm putting here the crown lengthening evolution as the way that we see. Okay, we started freehand. I think it's 100% depend of the operator skills. So it's something that is really predictable for like amazing surgeons, but not for everybody. Okay. Then we started to change to like a 2D DSD and try to make some measurements to bring this to a freehand world. Then we started to work with mock-ups. So we did like a, let's say, planning walks up, and we send this to the mouth by using like a mock-up. And the way that we are now, the perio guides, the digital perio guides that really help us a lot. So thinking about like a perio guide, I just want to show you guys two different situations. One patient that I treated that didn't come to me for anesthetic rehabilitation is just a patient that was not like happy for with the gum smile. And then we decided just to do a static crown lengthen using the natural shapes just to make a better look, okay? Not going to change anything. So look, what do we need here to do that? So our reference is going to be the CJ of the patient. So what do we need? And I treated this case with the DSD team, the DSD Planning Center from Madrid. Okay, I like a lot the work that they do. It's pretty good. And what do I need to plan in this case? First, we need face pictures, just to show to the lab and to bring information to the lab. What do we need in the patient the smile? Then we need the CBCT. Do you want to ask something, dear?
It's just with a quick a heads up with regards to the images that we're actually watching. Are these are these from the Smilecloud platform? Are these, could you maybe just give a bit more insight as to what the actual examples that you're using?
Of course I will do. Let me just go through this case because I didn't use Smilecloud here. I used it in the second one. So if you don't mind, I can show this in the next case. It's okay for you?
Okay, yeah.
So I did summarizing, face pictures, tomography, scans, and look how nice it is. So what they are doing here, just taking the initial situation, we are superimposing the DICOM, we are superimposing the intraoral scan, we are just exactly marking where is the CJ and bringing the natural form of the patient as like a natural donator, you know? We are not using like a library of teeth. We are extracting from the patient the teeth and using this as the reference, okay? She's going to be the donator. I mean, we are just checking where is the CJ, bringing exactly how much I'm going to cut to be predictable. And this is something very nice. As a clinician, for me, this is amazing first, because I have a lot of reference to diagnose. Second, the technique that I'm going to use. And third, the communication with the patient. I mean, I can sit with the patient and I said, look, this is a case that I need to cut the soft tissue, that I need to open the flap, I need to do a bone reduction. Oh, yes. Why? Why? Because we have all the measurements here. So I can show to the patient. So why not? I just open a screen and look, this is how much you have now. This is your diagnosis. You have like bone excess, soft tissue excess. So I need to cut this amount to bring your proportion to a very nice situation. I know that this is going to be an open flap surgery. Why? Because you have a lot of thickness. So I need to reduce like that. And with this, we just develop like a guide. Okay, this is the perio guide from the DSD. We print this, we bring this to the mouth, and then we just start to cut. And then you use your instruments, preference instruments like blade. You can use electrosurge. You can use lasers to do that. But you can really be sure that you cut exactly where you plan. So this is really amazing. And because of we did like a perio analysis, we don't need to probe during the surgery. Oh, we need to open a flap or not. No, you know exactly that you need to open a flap. You go there, you open your flap, you reduce your bone based on the measurements you did during the perio analysis, and then you just put the guide again. You use the reference of the guide to cut the bone also to really achieve that predictability we want. You check with the guide, everything is there. And this is something nice. Why the guide is amazing? Because you put energy in the plan, okay? And then when you execute, you know by using face pictures that everything will be aligned with the smile. And it's not going to be canted. It's not going to be strange. So because of the files, you know that when you finish, and this is the images after the surgery, initial situation, the planning we did with the 3D, and the final situation, pretty close to what we wanted. Okay, this is just an idea of by using a perio guide, and Hayley, to bring to you the other softwares that we are using. Look at this patient. I also treated here in Brazil with now my friend Thiago Toboni, and now we use it different approach. Okay, so we use it as Smilecloud as the software we wanted to plan, because this patient came to us again with the gummy smile issue, okay? But she wanted also not only to make a better look, but also to make some small corrections with the smile, okay? So we decided, as the patient was like young, to 25, 26 years old, I don't remember, we decided to do with composites, okay? Just to be less invasive with preps. Thiago is a pretty good guy for these kind of things. So here with MetaLab from Romania, we just used Smilecloud to design. So this is the design part of Smilecloud. Gabriela did all the design. And what we are doing here? We use artificial intelligence from Smilecloud to bring libraries and to do a smile design using natural shapes. So you can change, you can show to the patient, you can do like a 2D mock-up and show this to the patient and say, what do you think? Do you think it's nice? And if you look to the video, you have like a chat, which is also nice from the Smilecloud, because you do that with the lab sends this to you, you communicate with the chat, you have everything in your phone because you have like an app. So you know that everything is nice. And here, again, with Smilecloud, you can see one also part of Smilecloud, which is the review part. You superimpose everything in the same software. So for me as a surgeon, this is amazing because I know that I can open or not the flap, if I need to reduce bone or not. And I show this to my patient. Look, I'm just doing like cross sessions showing, and this is the STL file from the mockup, okay, the design, and the tomography. So I can show to the patient that based on the future gingival margin, I don't have space to the bone. I don't have, I'm not going to have a stability. So I need to reduce bone, and I need to reduce bone opening the flap, because if I go for cross sessions in the posterior areas, I can see that I have a lot of volume, and the patient was not happy with the volume. So we decided to do one-step treatment, okay, which is bringing the design to a technique that Thiago Toboni developed, which is the technique of the guided composite technique. So we printed 3 different guides for layering composite based on the design. Okay, we print also a guide for the perio surgery. So everything based on the design, and during the surgery, just connect the dots. We use that guides based on the future margin. I like to use a lot of electrosurge to do that. So I just go there, cut the soft tissue perfectly. I don't have any bleeding with this instrument. So then Thiago can come, isolate, do all the steps from the composite, okay, using the guides. The guides is exactly the forms that we selected by using Smilecloud, okay? We do all the composite treatment. After finishing the composite treatment, I just open the flap because I know that I need to open the flap. I cut the bone, base it on the design that we did, base it on Smilecloud, base it on the guides that we developed to this patient. We finish the surgery doing our sutures, and in one single procedure, you can finish the treatment with aesthetic rehabilitation with composite and crown lengthen. So it's nice because I think by using technology, you really not only diagnose very well, execute very well, but you communicate very well and you save time. So that's why for me, in this kind of soft tissue procedures, technology really helps us a lot.
Can the technology give you kind of a time scale, an idea of the time scale for this kind of procedures, or is it just uniquely there to provide you with digital guides and insights?
I think you save a lot of time. Actually, I think when we are talking about time, if you're not into the digital world, you think that you are going to put more time planning, you know, but that's why as a clinician, I like to work with good labs, good planning centers, because you save a lot of time with that experience. So I send to them exactly what I want. I plan with them, but the files, the match, the planning in advance, I just go there and said, okay, change this, change that. I save a lot of time. And when I execute, thinking about like the procedures, I think in my clinic, I save half of the time if I compare doing everything freehand. I mean, I don't have experience to be a prosthodontist. So every time that I need to do like a provisional, I put a lot of time. So bringing this to the digital world with all the design, I save like 0.5%. Implant, placing implant for me, it's sometimes more than half of the time. So I think I can work 2 times faster in my clinic. And also for the patient, when you combine this kind of treatment that is possible with guides and everything, sometimes you say to the patients maybe weeks, months, and it works very well.
Oh, good to hear. I'm just going to address the people that are connected and that have joined us for this session of Just Ask, because I'd just like to have maybe some of their feedback and their thoughts on these procedures and these techniques, and utilizing your workflow, of course, and view to maybe they use an equivalent of Smilecloud, what their thoughts are on that. Has it helped them? Are they maybe wanting to take a big step into kind of exploring more the digital world and having that accompaniment as well? Please don't hesitate in asking any questions, or just sharing your experiences in the chat, because I think it'd be great to get some feedback from you as well, to hear your thoughts on what the doctor's just been mentioning. So maybe we could move on to the next specific case that we of this Just Ask session. About the workflow guided surgery for implants in aesthetic zone.
Yes. What was the question, dear? Sorry.
Sorry, we're just with the third point, because we've kind of addressed, the virtual plan for perio-implant surgeries, the workflow for guided surgeries for implants and aesthetic crown lengthening. I mean, maybe you have another case and any kind of other examples that you'd like to share with us.
Of course. Look at this situation, how nicely we can achieve. Also, a case that I treat with my guys here in my clinic, and I think it's nice because we already discussed about a case with one single central in aesthetic zone, which is for me also it's like a huge responsibility. But I think in these cases that I'm going to show now, it's also related to the first questions you did. So if the patient doesn't have the adjacent tooth, or like an ovellus or a root to copy, how do we do? It's like this situation. When you have like a genesis situation, and this is not like very, very common. But when you have patients to treat like this, you don't have room to mistakes. You know, it's very delicate. You don't have space to make mistakes. And I see a lot of mistakes in this kind of cases. So again, how technology can help me here. First, the patient came like this. It's a patient that came with missing two laterals, okay? So together with a friend, we did the ortho treatment. And how do we monitor the ortho treatment? We just design the first look. What do we want? So the ortho really can move the spaces perfectly where do we need. After finishing, look at the situation, okay? With this situation here, what do we need? First, we need to do a tomography, okay? Actual situation, scan my patient, actual situation, and then we move to the software. And in the software, how do we manage the aesthetic zone? First, we do a very nice design. So we design the laterals perfect as we like. We show this to the patient. The patient said, okay, this is something nice. I like the forms. I like the way that you design. Nice. It's approved. Then you plan your implant position. And something very nice from this case, it's a very delicate point in the agenesis case. Sometimes in a genesis case, you have a very flat ridge. And with this flat ridge, if you don't be very delicate, you are going to miss one very important step, which is doing your osteotomy to bring space exactly to where your design is going to be. So with the digital plan, you can plan exactly perfect where it's going to be in the implant and exactly how much do we cut the bone. And why is so important to cut the bone here? Because you really need to develop a scallop design of the bone, okay? In order to create space to play with the emergence profile. And by doing this, we know exactly how many millimeters you want to cut, how many and which burr you're going to use to cut perfect and precisely. You can use guides to do that. But this is something very, very important, okay? If you do this freehand, it's going to be a guess, okay? You can achieve, but why not knowing exactly how much I need to cut to make a perfect emergence profile? Then again, I'm going to place my implant with the guide. I don't have space to make a mistake. And then again, we designed it perfectly, the provisional and the shapes to guide the soft tissue. And this is something that you asked me, how did we do this? By, of course, doing like a digital design, but using natural roots and a library of roots to bring exactly the profile that we want and bring exactly that design to the position by using guides to bring exactly the provisional where we designed it. And this for me as a surgeon, it's amazing because I feel more comfortable of not making mistakes. I put the emergence profile exactly where it needs. The bone is exactly where we need. So we just need to do our job now. Now it's based on experience and skills by doing grafts, by using your experience with sutures. Now we don't have technology together with you. You have your experience, everything that you need. But look at the design. We finished the surgeries like this. But the healing works after 3 months. We just scan and look at the situation now. It's not 100% perfect, but it's pretty natural. Looks nice. And for me, the best thing is technology helped me to design, to bring provisional, to place the implant perfect to the position, to not make a mistake in a place that I don't have room to make a mistake, and to finish nicely in a very natural situation as the patient wanted.
Dr. Giordani, I have 2 questions. Nicole wants to know how much space is a minimum that you want to open orthodontically to decide to move forward with implant treatment in the upper lateral position. So how much space is a minimum?
Sure. Perfect questions. Really depend of the implants or the system that you use. Okay, but usually for laterals we use narrow platform implants, like 2.9, 3 millimeters, 3.3, something like that. Okay, so the system I use is 3.3 millimeters. Okay, so in order to have like 3 millimeters, 3.3 millimeters implant, 1.5 millimeters space from my implant to the natural teeth, 1.5 millimeters from my implant here to the natural teeth, I need 3 plus 3.3. So basic 6.3, 6.5 millimeters is minimum space to do that.
Okay, Maria Margheriti, wants to know, how do you measure the distance between the gingiva and the bone and the height of the sculculus? Because these distances are a little different from patient to patient.
How do I measure? Tell me again.
How do you manage the distance between the gingiva and the bone and the height of the sculculus? How do you manage?
You are talking about like crown lengthening, probably.
This is the question that Maria has just asked. Wouldn't this be dependent on the? Isn't this something the digital guide would be able to define and determine?
Yes, I think we were talking about the last case, but I can answer the two situations, okay, if you don't mind. I mean, if we are talking about the crown length, how do we measure, like, where I'm going to put the soft tissue and where I'm going to put the bone, okay? When you cut this relation, of course, needs to be related to the tissue phenotype. I mean, when you think about like a supracrestal attachment or biological width, okay? When you cut the soft tissue and this distance from the future gingival margin and the bone needs to be related to the tissue phenotype. It's not 3 millimeters for everybody. So what do we do in the software? Let me go back to the other presentation because it's going to be easier. This is exactly what we need here. We measure the soft tissue thickness, okay? So related to the soft tissue thickness is our supracrestal tissue attachment or our biological width. I mean, if I have a thin tissue, thinner than 0.9, 0.8 millimeter, I will consider 2.5 millimeters from the soft tissue to the bone, okay? If I measure more than 1 millimeter to 1.3, 1.4 millimeter, I will consider the average biological width, like 3 millimeters from the soft tissue to the bone, okay? So I'm going to cut the soft tissue and I'm going to add 3 millimeters. The bone level is going to be there. So I need to do also a bone cut if it's necessary. And if I have more than 1.5 millimeter of soft tissue thickness, okay, I'm going to add 3.5 millimeters of biological width. So this is the relation for me. And of course, technology like in this perio analysis is going to help me a lot. I can measure and I can just add exactly how much do I need for the biological width, okay? Thinking about implants, okay? If it's like in this case, how do I measure the bone level to the soft tissue level? Depends on the design, okay? So if I design my teeth, my tooth exactly here, so the bone, it's going to be about 3.54 millimeters away from that soft tissue level. Why? Because it's going to be my implant depth, okay? And then I will have 4 millimeters to work with my emergence profile. So I design, and then I'm going to understand perfectly where I need to cut my bone to have space to play with my emergence profile. Because if I design perfect like this, and I don't have like this 4 millimeters of space, I have like a very flat ridge, I cannot like start to press and compress and make this perfectly my emergence profile with my provisional or my final restoration. And usually if we don't do in these cases, you finish with a very round restoration because you cannot do the emergence profile. You're going to have like short papilla and a very square tooth. So based on the design, I just consider the bone cut about like 4 millimeters away.
Okay. Dimitar wants to know when and how do you decide to go with tie base or one abutment one time, cemented custom abutments or anterior cases?
Super nice question. So how do I plan my provisional restoration? So usually the way that I like to use, which is connecting the provisional inside the mouth of the patient, okay, using a milling process. If I don't have like a very delicate situation, if it's not a reconstruction situation, if I have good amount of bone, I like to use tie bases and a milled restoration provisional. And then I connect this inside the mouth. Why I use a tie base? Because thinking about a software and the libraries, the only way to design something or the best way to design something and to connect inside the mouth with exactly the design, it's going to be the tie base. I cannot use like a provisional cylinder to do that. I need to cut and it's impossible to do this digitally. So I use a tie base to connect. The height of tie base, it's going to be selected also from the implant planning. I mean, I place my implant and the height of the tie base, I mean the intermediary height of the tie base, it's going to be selected depends of the implant depth. And usually the system I use, I have 1.5 millimeters tie base intermediary and 3 millimeters. So usually I use the 1.5 millimeters, but I plan with my virtual plan if it's possible, if my tie base is not going to hit the bone, okay? Otherwise I change to 3 and maybe I put the implant a little bit deep. When I change to the one abutment one time situation, I mean, using like a connect or any other prosthetic component, one abutment one time is a very nice situation for me when I have like a very delicate situation. I don't use for all my cases. I like to use for delicate cases. I mean, I have a case with no buccal bone, very delicate soft tissue, very delicate patient. Then I like to use this intermediary abutment with the concept of they stay in abutment, like one abutment one time. So I just put this intermediary component. I just seal everything there. And I'm not going to connect and disconnect anymore inside the bone, which is something very nice for me when it's delicate and I'm doing like multiple restoration or a very delicate, simple situation. These cases, I like to use the connect or the concept of one abutment one time. And then as I'm going to use like a tie base, I also need to plan the height also in a virtual plan. And then I mill everything, it's the same. But this is my, let's say, decision-making process, let's say like this.
Okay, we have time for one more question, and it's from Rida Mbarak. A very good presentation. Do you think that the position of single implants in an aesthetics zone still the same with time? Same with time. I'm not sure. THD, same.
I understood.
THD, same with time.
You mean if it's safe to do that and it's going to stay like for a long period of time with the same result? That is the question. I mean, the stability.
Yeah. Let's go with this. Let's run with that.
I think the question is about the stability, and this is a good conversation and great discussions today. My opinion, okay, it's I know how safe it is, but I know that if I do this in a very young patient, like from 20 to 30, I know that some patients is going to change, and sometimes I need to redo in after years, after I don't know, maybe 10 years or something like that. Then I see a lot of discussions, and also when I was in Lisbon in this amazing event from EAO, the discussion was exactly like this: should we place implants on single units in aesthetic zone? Or should we go for removable things or Maryland bridges or something that we know that we control better. My opinion is that when I have a patient with more than 22, 23, 24 years old, I like to use, and I know, and I talk with the patient that maybe after years, something can change. I mean, occlusion maybe can change, and sometimes we need to do like a liner or aesthetic movement with ortho to compensate, or you can change the restoration after 10 years and maybe change the profile, do like a soft tissue graft. But I get to my patient, I give to my patient something good that works very well, that is really good aesthetically, no one can see, and it's going to be very good for very important years of the patient. I don't like to use like a Maryland bridge or like prepping the tooth around to do something that is not an implant. And this is my philosophy. I respect other opinions, but I think it's pretty safe. I know that changes can happen, but we are ready to really solve the problems in the future, and small problems of occlusion we can solve. I was checking the Iñaki Gamborena lecture about this, and he likes to splint, I mean, the other teeth when he does an aesthetic implant. And I think something very clever for cases that are like very risky for that. So many options. I know that a few patients will change, but I think it's better to still use implants for aesthetics on implants. And if it's necessary, just change something in the future.
How do you think digitalization of dentistry will change or evolve the role of the dental professionals over time?
I think already changed it, in my opinion. And it's changing faster and faster and faster. I think when we talk about digital, we don't talk only about guided surgery. Digital is everything. Digital is like communication, the process, the labs, the way that we digitalize the patient, pictures, intraoral cameras, scans, printing machines, milling machines. I mean, all the process now in dentistry. Even if you are not like a dentist that use the things in your computer like software, you are part of a digital process in dentistry. So everything is changing to digital in the world, and in dentistry is the same. So we really need to think about something good for us that really brings for our more reliability, more predictability, better communication, better things, matching colors. I am a very big fan of digital, because for me, in my daily practice, really helps me. So change everything for me will change everything from me and from you, for you. And I think we need to be open for that, not understanding that this is the result and this is the key of everything. Biological concepts are the most important thing, but we need to be open to the digital world to help us in the process of achieving results. I think it's nice also to diagnose. I think it's amazing.
Yeah, we have to be open to change. The digital revolution is already upon us. That is all we have time for, actually, Dr. Giordani. Thank you so much for your time today. Thank you for sharing your insights, with your fantastic case studies and such like. It's great to see that and be a part of it, and of course to have all this interaction from around the world. Just one last thing, because I keep on getting messages. We have people connected from Peru, from Istanbul, from Norway. I mean, it's so great to see that we're really kind of bringing professionals together to hear an expert deliver such a great discussion. So thank you very much for that. We really appreciate it. Now it's just a quick reminder that our annual Congress at the EAO-DGI joint meeting will be held from September the 28th to September the 30th. Now this year, we've joined forces with the German Association of Oral Implantology for a high-level event. Now, on top of many EAO membership benefits, EAO members can still benefit from early bird rates until July the 21st, so don't miss out. Register today to the Congress, and all of the information is on the link below. Once again, Dr. Giordani, thank you so much for your time. It's been great to have spent this just our session with you here today.
Thank you so much, dear. It was a pleasure for me. Don't miss the presential event because it's going to be amazing. And for me, it was an honor to be here with you and all the guys here around the world. Thank you so much.
Absolutely. And thank you everyone for joining us today. This will be available on replay, so please don't hesitate in sharing it on your social networks. Thank you very much. Take care and goodbye.
Take care.